as well. So maybe you can speak a little bit about some of the challenges that they went through. It's such an incredible story that I just assumed it was, oh, super easy. Everyone, it seemed like a very clear thing, but that is not the case at all until I learned it very recently.
Yeah, in fact, universal health coverage is a relatively new thing. There are a number of countries that had some form of social health insurance for those folks who were employed in factories, etc., in Europe from an early period, but that was not universal health coverage. That kind of coverage only applied to them, and in part because they paid into a system that their employers contributed to. The government provided legislation that basically ensured that it was mandatory. But if you weren't working in a factory, you were self-employed, or you had part-time employment, seasonal employment, or you were an agricultural laborer, you wouldn't be covered by that system. So it wasn't really until the Second World War and after that ideas of universal health coverage started emerging. And even then, there were countries in which they never really did move to universal health coverage. Instead, they subsidized um, access for certain groups of people, but not for the entire population. And that's what we mean by universal health coverage, right? And in fact, Saskatchewan was at the very forefront of introducing universal health coverage. The only other country that had attempted, jurisdiction that had attempted to do it in the late 30s and early 1940s was New Zealand. And there were problems with its implementation, and they still had user fees. Doctors still charged extra billed, we call it. And so it wasn't the kind of free access that Tommy Douglas wanted in Saskatchewan, and he ensured that the system delivered that so there wouldn't be any financial barriers to access, whereas the New Zealand system had some. So then it took another 18 months after universal hospital coverage was introduced in Saskatchewan before the United Kingdom implemented the National Health Service. And there was no costs associated with access to hospital care, doctor care. Um, and it was intended to be a system, so they took over all of the hospitals. Douglas did not do that in Saskatchewan. The hospitals are still being run either by municipalities or by the Catholic Church or by other organizations. Uh, and instead, he paid for patient care, and they received most of their money through payments directly from the government to cover off patients, and they could no longer charge patients for that care. So that's what we mean by single payer. It was really, in my view, the first jurisdiction wide single payer system in the world. Followed by, of course, the National Health Service, which was designed differently, and then universal health coverage in other countries slowly began to emerge, but there was always a fight because there were always groups that were dead set against it. You know, generally uh, corporations would have a lobby against it. Doctors almost invariably through their medical associations in whatever country were against it. Some of them fought. They actually went out to a full strike against and trying to prevent universal health coverage from being introduced. I did an article with a friend of mine from Belgium because we were comparing the doctor strike of in Saskatchewan in 1962 to the general doctor strike in Belgium in 1964. But it was exactly the same issues that were involved. So it was very, very difficult to introduce universal health coverage. And you could do it in stages. So hospital coverage came into Canada by the late 1950s, early 1960s, based on the Saskatchewan model. And there wasn't a lot of opposition to that. There was some, but not a lot. But when it was extended to physician coverage, then the opposition really kicked in. And it became a struggle, not only in Saskatchewan, but in other parts of the country as well.
And that's so interesting because until I heard this the history of how Tommy Douglas and the rest of his team was able to usher in coverage from a primary care perspective, I did not understand that doctors were so against it, at least in the beginning. Right now, most you we actually recently had Dr. Josh Reimer on the podcast. She's the president of the Canadian Medical Association,
Yep.
and of course, nowadays everyone's super for it, right? It's like, oh, us compared to US, look how terrible their system is compared to us. Like that's simplifying it a little bit here, right? But it seems like everyone is so behind it. But there was a strike that actually happened, that doctors didn't actually want that to happen. So what what essentially forced it, or not, maybe not forced is not the right, what convinced the doctors to go, hey, you know what, maybe we should give this a try, and this is perhaps the right way to go.
Well, I don't think it was about convincing them at the time. And I should make a distinction between doctors and organized medicine here. Uh, these are the organizations that speak for doctors, that, in a sense, represent them politically, from the Canadian Medical Association to all of the provincial medical associations, and the leadership in those bodies. And it was organized medicine that was dead set against it. Of course, there were doctors, some of them working in rural and remote areas and other places where who were more sympathetic to the idea, but they were definitely a minority. The majority of doctors supported their medical associations in their positions. They elected them, after all, to those positions, and were dead set against the idea. And it took time after Medicare was introduced, first in Saskatchewan, then in other provinces, for it to be accepted. But keep in mind that, there was not only a doctor strike in Saskatchewan in 1962, there was also a strike by medical specialists in Quebec in 1970 when Medicare was introduced there. And when the provisions against extra billing were introduced by the Ontario government in response to the Canada Health Act in that period shortly after 1984, doctors went on strike in Ontario as well. So there's a history of this opposition to Medicare and certain dimensions of Medicare from the very beginning. And the medical associations, especially the Canadian Medical Association plus other provincial medical associations, were dead set against the single payer design and instead argued in favor of a multi-payer system in which individuals who could prove they could not afford to buy private health insurance would get a subsidy from their governments to be able to purchase private health insurance. That was their preferred system for many years. And they were these associations were very upset that governments chose to adopt Douglas's model of single payer and single tier. Now, what do I mean by single tier? Just very quickly to explain what that is, because everybody knows what single payer is. That means the government pays all the bills. There's no insurance companies involved. But single tier is a bit of a harder concept because we've never known any other system in Canada. So we just take it for granted. But in most countries, there are two parallel systems. There's a public system of hospitals and doctors, and there's a private system of hospitals and doctors. You can purchase private health insurance or through your employer get private health insurance, and you have exclusive access to the private system. If you don't have that insurance, however, you have to go through the public system. Invariably, however, the problem is that in these countries, uh, the private system uh, probably has fewer wait lists. It is easier to get into, and you don't have to sit in an emergency department waiting room with people that you may consider riffraff. You're with people that can afford to pay or that have really good jobs and have really good insurance. Um, and so you're divided. The population is divided. The facilities are divided. The providers are divided. Canada does not have that system. The vast majority of doctors have Medicare patients. There are a few private doctors. There's nothing preventing doctors from setting up a private practice, but outside of the largest cities, there's very little sort of business case for it. So most doctors basically have Medicare patients. There's no such thing as hospitals that will not admit you on the basis of your Medicare card. Basically, you have access to all hospitals in the country. That makes our system very different than other systems. Even the National Health Service in Britain has a small private tier, right, that's separated from it. Most of the continental European countries have that system. The big exception in Europe are the Nordic countries: Norway, Sweden, Finland, Iceland, Denmark. Those countries also have single tier systems. So Canada and the Nordic countries and a few other countries in the world, we have this, it's a minority position, but we have single tier systems where we don't basically exclude people from a certain private hospital because they don't have private health insurance. The thing about it is that it's not, we don't care whether it's a private or a public hospital. And Ontario, as you know, most hospitals are private, not for profit hospitals, but they have to accept, and they do accept, all patients, right?
Got it.
So it's not about the ownership of the delivery system, it's about the rules of Medicare, which means the rules say you have to have access to all the facilities. It's beginning to break down a little bit in some places in Canada, and that's very concerning. And I know Douglas would be rolling over in his grave to know that, because he always intended it to be a single tier system.